success.
Welcome everyone to the European Society of Contraception and Reproductive Health webinar about breaking barriers, building bridges, contraceptive access for all. And this is to celebrate World Contraception Day, which is today. My name is Nicole and I am a member of the Science and Education Committee of the European Society of Contraception. And I work clinically as an advanced nurse practitioner in sexual and reproductive health in Edinburgh, Scotland. And I'm delighted to be co-chairing this event today. The webinar is sponsored by Bayer and we're very grateful for their support. They've had no influence on the content of the webinar, but their support is very much appreciated. And I'm delighted that so many of you have registered and joined today. We have 575 participants who have registered and we're all here to celebrate World Contraception Day. We all know that contraception is important for choice, freedom and reproductive rights across the world. And World Contraception Day is an annual event that takes place on September the 26th every year. It's a global campaign that aims to improve awareness of contraception and enable young people to make informed choices on their sexual and reproductive health. The campaign encourages a culture of empowerment and helps young people make informed decisions that shape their futures. And the campaign is supported by a coalition of international partner organisations. And we have a really exciting programme planned for today with 4 wonderful speakers. We have James, Kiarie and Petrus Steyn from Switzerland, and they will be talking about multi-purpose prevention technology. We also have Alison Edelman from the United States, who will present some analysis and data evaluation of digital health apps. And Philipp, Quaas, who is from Switzerland and is also our co-chair today, will be talking about novel contraceptive methods and myth-busting. So we'll hear from all 4 speakers first, and then we have time at the end of the webinar for a Q&A. So if you could please submit your questions into the Q&A section, which should be visible on your screen. Then myself and the speakers will answer a selection of these questions, and you can upvote each other's questions by liking with the thumbs up sign. And that just means that we will definitely see the ones that you really want us to see. And if you could note who your question is for, that's also helpful for us. I'd like to hand over now to my co-chair, Philipp Quaas, who will give you some general information about the ESC.
Thank you, Claire, for this wonderful introduction, and happy World Contraception Day 2025 to everyone. So I want to quickly talk about our society, the European Society of Contraception and Reproductive Health. The mission of our society is the following. We are a leading professional society working collaboratively in Europe and beyond to champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decisions in choosing and using contraception. And you can become a member of our society, and there are a lot of reasons to do so. 4 reasons are shown here. You will have free access to our webinars exclusively. You will get our regular newsletter. You will have reduced Congress fees and registration fees. And you will have access to our journal, the European Journal of Contraception and Reproductive Health Care, which is one of the leading journals in the field. And I want to invite you to our Congress, the 18th ESC Congress, which is taking place in beautiful Belgrade in Serbia in May next year. The theme will be Breaking Barriers in Sexual and Reproductive Health. And the registrations are now open, and you can submit your scientific abstracts until December 31st this year. And I also want to use this occasion to introduce a new social media page to you, because on this special day, World Contraception Day, we choose to launch a new social media page, which is intended to educate patients and women worldwide. They can ask questions and put concerns regarding contraception and reproductive health on this new social media page. And you can discover more on our social channels on Instagram, Facebook, and LinkedIn, and be part of the conversation. And please follow us on the social networks. Thank you.
So I'd like to introduce our first two speakers. We have Dr. James Kiarie, who's the Head of Contraception and Fertility Care in the Human Reproduction Programme at the World Health Organization. He has over 30 years' experience in teaching, clinical practice and research in sexual reproductive health, focusing on contraception, fertility care and sexually transmitted infections. We also have Petrus Steyn, who is a scientist and also a trained obstetrician gynecologist and social scientist, and a researcher in the Contraception and Fertility Care Unit in the Human Reproduction Programme at the World Health Organization. He currently leads, amongst other studies, implementation research on integration of HIV preventative measures in contraceptive services in South Africa and Eswatini. And we're just waiting for, I think it's James who's going to share his slides. There's always just a wee bit of a delay as the slides come over. Perfect.
Yeah, thank you so much, Nicole, for that kind introduction. And thanks so much to the organizers of the webinar today for inviting us from WHO to present on multipurpose prevention technologies. So as we, I hope my slides are moving.
They're not moving yet.
Yeah. Okay, thank you. So I think just to kind of set up the scene, we really need to see that issues of pregnancy prevention, STI prevention, and HIV prevention overlap, and they share very similar challenges. I won't go through all the overlaps, but I would just like to highlight one about the very high frequency of unintended pregnancies. 6 million every year, and also the very high burden of HIV, particularly in sub-Saharan Africa. So there's a lot of overlap in these areas. And
James, we can't see your slides anymore.
Okay.
Sorry.
Can you see them now?
It looks like they're just coming on. I can't see them yet. It's a blank screen.
Sorry for this.
That's them back now, James.
Yeah. Are you able to see them now or not yet?
Yes, yep, we can see them.
Petrus, are you able to share from your side?
think that James might have problems with the connection, right?
Yeah, I wonder if maybe Esther or someone could maybe share the slides for James. That might work.
James, do you prefer that I share the slides?
Yeah, maybe share from your end, because on this side I'm not, looks like I'm not able to share.
Okay, you're sharing now.
Now you can see the slides?
Yes.
Okay. Yeah, and apologies for that. I'll still, I think, be able to try and cover the content on time. So as I've said, there's a lot of overlap in these areas of prevention. And the reason why we really need multipurpose prevention technologies have been highlighted in the recent ECHO trial, which showed that there was very high number of HIV infections and other STIs among women seeking family planning services. So this actually provides an opportunity for this prevention to be done jointly. However, I would like to highlight that there are some opportunities and challenges for multipurpose technologies. Let me start with the opportunities. One, of course, is that they can provide simultaneous protection against HIV, STIs, and unintended pregnancies. And they can be very empowering because at one visit, clients can be able to cover all these three needs at the same time. And there's also opportunity to think of MPTs not as replacing our current efforts, but working in a complementary manner to existing prevention strategies like PrEP, antiretroviral therapy, male circumcision, and even contraception itself. But there are some challenges that we need to be aware of. One, of course, they are very complex products, which pose challenges in terms of programming, but also in terms of regulatory issues and in terms of thinking about training, supply chain, and even policy alignment. There is potential for users to have challenges because their preferences in terms of what method they want to use for preventing infection may be different from what is available as an MPT. And importantly, we have to remember that there is no magic bullet. They will not be the solution to everything. I think our efforts to provide contraception, HIV prevention, and STI prevention separately have to continue. And there's also a challenge that they can reduce the focus on individual needs for each of these areas. I would like really to highlight our existing guidelines for HIV, STI, and pregnancy prevention, because when we think about multipurpose technologies, they will have to come at the nexus of these guidelines. So current WHO recommendations around pre-exposure prophylaxis, we have 4 recommended preparations in terms of tenofovir, which is available as oral tablets, the vaginal ring with dapivirine, 2 long-acting injectables, cabotegravir, which was approved in 2022, and lenacapavir, which has just been introduced in 2025. And in terms of STIs, the key thing for STI prevention is that WHO recommends a decentralized approach, which I think fits very well with what we are doing with contraception. They really recommend integration and using trained practitioners to deliver the services. So there's a lot of similarity in terms of the approaches recommended for both HIV and STI prevention with what we recommend for contraception. We have these 3 guidelines on contraception. One is the medical eligibility criteria that focuses on safety of various contraceptive methods. And the other one is the selected practice recommendations, which has recommendations on how to use methods safely and effectively once they are deemed to be medically appropriate. But a big emphasis in contraception guidance is the issue of ensuring human rights in the provision of contraceptive information and services, particularly emphasis on non-discrimination, availability and accessibility, high-quality services, ensuring privacy, confidentiality, and informed decision-making, and also a participatory and accountable process. Having said that, I just wanted to highlight that on the pipeline, in terms of research and development, there are several MPTs. This is information from the Initiative for Multipurpose Prevention Technologies, and they are in all formulations in terms of rings, gels, fumes, injectables, oral tablets, and implants, and others. The one which is the most advanced is actually oral tablets, which are now, I will talk a bit more about that shortly, but there's under development all these forms. I would like to mention condoms, because these have been available for the longest time, and they are actually a multipurpose prevention technology. They are effective, both for pregnancy, for STIs, and also for HIV infection. They are safe, inexpensive, and really we should not forget that condom use has been responsible for a lot of STI and HIV prevention and prevention of pregnancy for a long, long time. So they've really played a big role as MPTs. But I did mention about what is most advanced in terms of development, the dual prevention pill. This is a daily oral pill that prevents both HIV and pregnancy. And basically, it is a co-formulation tablet that combines both a PrEP, that is a tenofovir and emtricitabine, combined with an oral contraceptive. So they've been co-formulated into one tablet. And it is available as a 28-day regimen, 21 with PrEP and combined oral contraceptive pills. This is the pink pill, and 7 days with PrEP-only pills. This is the ones covered in peach. So this is the one which is most advanced in terms of development, and an expression of interest for WHO pre-qualification was submitted in November 2024 by the manufacturer. I've put there a link to the invitation for that expression of interest. And WHO plans to convene a guideline development group on this for both family planning and HIV prevention in Q4, later actually of this year. And following, if we do successfully get these guidelines, then we will move on to work with ministries of health and national programs in terms of introducing this as part of our HIV prevention and pregnancy prevention programs. So that's where we are. And apologies again for the problem with the slides. And I would like to hand over to my colleague Petrus, who will look at some of the work we have been doing around HIV and STI prevention and in family planning services, because it is very important context for us then to be able to understand how we see MPT programs being rolled out. And over to you, Petrus.
Thank you, James. Next slide, please. So at its simplest, integration is combining different kinds of services to maximize outcomes, and this can be bidirectional, with sexual and reproductive services integrated into HIV services or vice versa. There's an overlap of these services as both contraceptive methods and PrEP have to consider eligibility, client choice, contraindications, and time period needed for this. UNAIDS, WHO, and HRP have jointly called for an increased access to PrEP in family planning services, in particular in locations with high HIV prevalence, as well as in sites that serves key populations. The potential of integrating this PrEP into family planning services is clear, but how to realize it is not. Next slide, please. So we did a scoping review in 2022 to look at the mapping and synthesis of current available evidence on the integration of PrEP in family planning services. And not surprising, we found multiple barriers, but also facilitators that were identified impacting on the integration of these services. At the client level, there was the low risk perception of HIV acquisition of clients attending the contraceptive services. Some also said it was the age was too young, or the extra pill burden on the published data on oral PrEP at that stage was also a barrier. On the provider level, there was a lack of training and knowledge in the providers, as well as a lack of costing studies. In published evidence, little is known of how to best use these potential synergies of PrEP and STI services in family planning services. In that scoping review, the data of integration of PrEP into the services was limited most to studies from Kenya and the United States. However, as we know, in the past 2 years, the body of literature is really growing, but there's still information on implementation strategies needed for the integration. Next slide, please. You can actually skip the next slide, James, and move on to another slide. Skip that one. There we go. So just for time's sake, I will mention the objectives of the implementation, research, and scaling up of national programs on integration PrEP for HIV into family planning services. First of all, it was to explore the coverage and readiness of PrEP delivery where family planning services are provided. Secondly, it was identifying feasibility, facilitating and impeding factors that influence these services at different levels of the services. Thirdly, was to explore the stakeholders' knowledge and perception towards these integration services. Then, very important, fourthly, to identify the client's acceptability, perceived barriers and enablers on receiving this services within integrated services. And lastly, then to compile the above and apply them into frameworks for collaborated evidence-based organizational change. Next slide, please. As mentioned before, we are doing the studies in South Africa and in Eswatini. And this is studies, implementation, research embedded in current practices. So we don't, the intervention is what is on the ground. The methods is at multiple levels. For instance, in Eswatini, it is, James, you're in slide preview now. Just anyway, it's in multiple levels. In Eswatini at the national, provincial, district, primary healthcare services, as well as in the community. And we use different exploratory and mixed method approaches. And then lastly, with what we are busy at the moment with, is that the stakeholders, including the Minister of Health, will draw upon these findings to co-produce a strategy that addresses implementation gaps and leverage the synergies identified. Next slide, please. So just some preliminary data results that we have. First of all, on feasibility and acceptability of these integrated services. The integration of PrEP into family planning services is important, and it is deemed essential for improving access and reducing stigma associated with HIV prevention. The need for a one-stop shop approach where clients can receive multiple services simultaneously was highlighted, with the idea that it reduces wait times and increase the likelihood of uptake. So integration of PrEP and family planning services are feasible and acceptable to both clients and providers. And integration improves service efficiency, but requires health system readiness. Next slide, please. Regarding community engagement, role of community health workers and mentor mothers in Eswatini was frequently mentioned and deemed as crucial, especially for educating peers about PrEP to reduce stigma and increasing acceptance. The participants noted that community feedback is vital to ensure that services meet the needs of perception of potential users. So community engagement is really crucial. Next slide, please, James. Lastly, just something on the clients and provider concerns. Several respondents discussed the importance of the training to ensure that they are equipped to provide PrEP effectively, including continuous training and capacity buildings that were identified as necessary for maintaining service quality. Concerns were raised about the workload and the need for healthcare providers to manage multiple responsibilities effectively. So in summary, the clients really value reduced waiting times, the holistic service experience, and peer-informed outreach. There were concerns on the healthcare workforce readiness. Next slide, please. So if we look at, and this is really very preliminary summary findings on Eswatini at the readiness and coverage. There's a variability in regional uptake and implementation timelines. There are gaps of inconsistent availability of PrEP across the sites. Enablers and barriers. Enablers, they also come up with a one-stop shop integration that improved access and reduced stigma for HIV prevention if it was through the contraceptive services. Barriers were staff shortages, lack of training, and unclear protocols. Stakeholder perceptions were very positive, where their support from integration from the Ministry of Health, the regional managers, as well as the NGO. Concerns is increased workload, absence of national integration SOPs at that stage, and suboptimal task sharing. Client perceptions, strong interest in combined services. However, there is some stigma that persists, even though it is a little bit of a dichotomy there, that the stigma is reduced. Some people saw it as a reducing in stigma. Then community involvement is critical. So there's a lot of participatory action research in regional management meetings, PrEP board team meetings, and there's already collaborative efforts underway that have been changes. There's now SOPs, and these things are addressed in real time. Key inputs are really gathered for refining the implementation tools and policies. Next slide, please, and that will be my last slide then. If you look at key learnings from integration of HIV prevention for multipurpose technologies, first of all, it should be client-centered care, personalized counseling tailored at the needs for individuals. But Although holistic services should be framed within broader sexual and reproductive health context. The importance of training and capacity building is that there should be continuous education for providers that enhance service delivery and interdisciplinary collaboration between the HIV prevention and reproductive health providers. Community engagement and education is really important. Awareness campaign with community outreach reduces stigma and increases uptake of the services, and leveraging peer educators for relatable outreach and improve acceptance has also been shown to work. Integration into existing services. You should use the current family planning services, primary healthcare services to integrate it effectively, and the single visits and not queuing in line for contraception and then afterwards in a line for PrEP is of utmost importance as well, where you have to offer multiple health services in one visit to optimize clients' experience. And then lastly, the ever important regular evaluation of services that is essential for improvement. Last slide then. Thank you very much.
Thank you, both Petrus and James, for such interesting research. I'm sure there'll be plenty of questions at the end. It's now my real pleasure to introduce Alison Edelman, who is a professor in obstetrics and gynecology and the division director of complex family planning at Oregon Health and Science University in Portland, Oregon, in the United States. Professor Edelman's research team leveraged data from menstrual cycle tracking applications to determine whether the COVID vaccine caused menstrual cycle disturbances. And Alison did get up at 4:30 this morning to be here with us, so we are super grateful and delighted that you're here. Thank you.
Thanks, Claire, and everybody can see my slides okay. So I'm going to change focus just a little bit and talk about research like Petrus and James have done, but also how we can leverage femtech and the digital health apps, which I think are important for breaking down barriers with both our clients and patients, and then also researchers being able to kind of leverage this big data. So let's see if my slides move forward. There we go. I do want to acknowledge that I have had research collaborations with two of our tracking application apps, which are Natural Cycles and Clue. I don't have any financial interest in them other than just having the research collaborations, and that research was originally funded by the NIH, which has now concluded. Because we have such a short time, I thought I'd just briefly go over kind of the objectives with this talk today. I thought we'd examine the landscape of digital fertility awareness and menstrual tracking apps, be familiar with the potential of them and the differences in them of how they relate to the data, if you are wanting to look at that for research, or even it applies for client or patient use too as well, because all apps are slightly different. And then I think one of the things that people have the biggest questions about are the protections and the necessary stewardship for actually user data that we use. And then also I can talk a little bit about how users themselves can make sure that they're protecting their data too. So I think we all know that periods really matter, but this really came to a head during the pandemic when the rise of femtech and then the interest of people in tracking their kind of health and things happening in their health and biological functions kind of came to a head. And we all know, as most of us are probably in women's health, that periods are kind of a fifth vital sign for us. They help us understand the health of an individual, the well-being, but for individuals themselves, we have extensive public experience with periods. Half the population experiences periods. we actually spend about 10 years of cumulative time in periods because they happen every month for a week or more for some individuals. They have an impact on environment. They have an impact on our pocketbook because we're buying products to help with periods. They also can interact with education and work depending on how periods are for individuals. So we have a lot of experience in populations, and then we have a lot of focus on it in sexual and reproductive health, but it's woefully understudied, and there's extensive stigma, gender discrimination, myths, and misinformations for something that is such a common biological function. So all of that came together with kind of the rise of femtech and the digital capability of being able to track more. And I think social media has really kind of allowed people to identify that they can do this for themselves. And then also kind of just the push into person-centered care allows people to have this partnership with their healthcare provider that maybe in the past just really wasn't there. You know, it was more one-sided and the provider was kind of telling the patient. But now we have this person-centered care, client-centered care, where we're really having this partnership between both. And actually, a lot of this information can be incredibly helpful. I know as a clinician, you know, it used to be that people would sometimes bring in a paper diary of what was happening with their cycles, or they would describe it to you, and it was very hard to kind of see what was going on. And now I actually have individuals that are sending me or, you know, showing me what is happening in their digital applications, and it makes it a lot easier for understanding about what's happening. So why are people, just to talk about this a little bit more, you know, in the analog age when we're using paper diaries, and we are still using paper diaries for some things, you know, the research for it was challenging because if people were self-reporting data, you know, it was one of those things where we might not necessarily have a control group. We had people filling out the diaries in the parking lot ahead of time. So there was a lot of challenges with, you know, knowing if the data was really accurate or not. And the other problem with paper diaries, or just even tracking kind of at an individual level, we have a hard time identifying safety signals for something like the COVID vaccine, which we leverage this data for. It would have been very hard to do this in paper diaries. So by leveraging this big data that we can get almost instantly, we can see safety signals really rapidly, which is something that is incredible, an incredible resource. And then also just for researchers, you know, for the paper diaries, we were hand entering those. So there's always errors that happen in that too as well. So for why people are using it, well, you know, patients are using it differently than researchers are using it. And so, you know, people are using it because it's, you know, helping them with their goals or improving something. It's also giving them some increased understanding and insight. Some of these applications have some education around biological function and menstruation, and that can be super helpful and inform our patients and make a more educated population. Many people are tracking their menstrual cycles. Some people are doing that for pregnancy planning. Some people are doing it just for interest, and some people are doing it for pregnancy prevention. So there can be a lot of different reasons why people are doing it. For researchers, we're using it really for large scale data collection. We can get population health insights because there's so much data. There's a lot of different clinical research opportunities. It is reasonably cost economical to partner with these applications. And then the data that you can get is incredibly fast. For some of the surveys that we did with COVID and asking people about their vaccination, and granted that was during a time where people were at home and maybe had more attention to their applications, but we were able to pull data within just a couple months out of, you know, several thousands of people. So how is the data collected? Well, you know, users input the data, and so you can just utilize that data. So the data that's just inputted on a regular basis, and whatever the app is capturing and the user is inputting. So that data is kind of always there. And then there's project specific messaging, and depending on kind of that messaging, the application groups can target specific notifications to ask for additional information. And that really depends on how they target individuals and then link them. Really depends on how long the message is. Do you want something really fast, like what is their COVID vaccination status? Or do you have like a survey that you need to ask questions? And so they can do in-app messaging, which are kind of the shorter messages. And then they can also do links to surveys. And obviously in-app messaging is much easier for users of the application. So oftentimes you get better response if you have kind of shorter or smaller data needs. And then also the applications, or many of the applications, can do a specific research cohort for you. So your research cohort can be using a particular area of the application, and you can kind of pull that data out. So that is a different way to use the application. So maybe it's not necessarily a user that's using it daily, but you're using it for your research cohort. Now, the other thing about the project-specific messaging is, these applications they're businesses. And so with partnering with them as a researcher, we have to really work with them and what they're doing for their business and increasing and changing the application and making it more user-friendly and adding things. And we have to kind of fit into that as they're doing it. So that is something also as a researcher where you're talking to the companies and asking them, like, when do you think it would be best, or when do you have the bandwidth to be able to send out this survey? Or maybe it's not going to be this year because you don't have the bandwidth with everything that you're doing with the company itself. So I thought I'd just kind of give you two examples. These are the two that I know most because they're the ones that I partnered with research. So Natural Cycles and Clue. It's important to know that all applications, they're different. Everybody's different. And so it's important to know when you're working with an application or you're using it as a user, what may be useful or different, or trying out different things. So Natural Cycles is an application. It's a pay-in app, meaning you pay for the app. And users use it who are naturally cycling. So nobody is on contraception or hormonal contraception that's using it. And they may be using it for pregnancy planning or pregnancy prevention. But these are individuals who are not using something that's going to change their menstrual cycles. They have required data entry for cycle timing. So people you're supposed to time it and you're supposed to enter it so that their algorithm can work to give you the information that you need as a user to either do pregnancy planning or pregnancy prevention. There's optional data entry for other things, which will come into play when we talk about the data that you get as a researcher. And then they have an overarching consumer agreement for research. So when I was talking about how you get your data before, if the data is there and the individual has given the okay for consumer agreement for research, you can use that data for research. And so the agreement or the consent is already there. And we'll talk about that consent. There's still regulations around it. It doesn't mean that you can just look at it and publish around it. There's still regulatory things that you need to do, but you already have this consent. And people can deconsent. They can remove their consent too as well. And the companies make it easy to do that. Clue is another application. And so anybody who wants to track for any reason, there's a free and a pay-in type part of the app. There's no required data entry. So, it's the user can use it a lot or use it a little, and how they're using it depends on how it's going to work for them. And they also have a consumer agreement for research. So let's talk about consent, privacy, and protection. So as I mentioned, many of the applications, or at least the ones that I have worked with, have the standing consumer agreement. And then you have a project-specific consent, and that depends what you're doing for the project. So if you're just pulling the data as is, then there there may not be kind of an additional consent. But if you're doing something like asking people to go to a survey, then there'll be kind of a consent. If you fill out this survey, your data will be used for this type of research, and they usually list the researcher in that too as well. So people get that kind of consent like you would do a survey in anything else. The research itself has to undergo regulatory review from the researcher side, and actually the apps have regulatory review or are contracted with a company that does regulatory review as well. You have data transfer agreements in place, or you should. And then as well, the type of data that you're asking for depends probably also on the protections that you want to get for it. So most of the data that we utilize was pulled and given to us anonymously, but we did have some data that we used that needed to be linked. So those surveys that we had needed to be linked to somebody's menstrual cycles, but then once they were linked by the company, they were sent to us anonymously. And then, there are some instances where maybe you would be working with personal health information. And again, the consent process and the regulatory part of that would be different if you needed that information. And, additionally, not all companies are the same. Some companies sell their data to third parties. So it's important to have an understanding of which companies do that. Additionally, some companies may have asked for additional regulatory clearance from federal bodies like the FDA or CE in Europe. And so they have additional kind of privacy protections and auditing that they have to align with. So that also can help with privacy protections for individuals. We now in the United States are experiencing external threats, which I know have been seen and worried about globally too as well, with fears of regarding misuse of the data. This really has been on the individual side, where maybe somebody would get that information from their own phone or application, but not from the companies releasing the data. What's been interesting for us or helpful for us in the United States is many of these companies are not based in the United States, so they're not necessarily under the laws and regulations of US, and so that has been useful. So we have not seen the need for the companies to release the data, but we have seen some instances in the United States of individuals having their data accessed by law enforcement, which of course is a violation of human rights. So when we get this data, it is a tidal wave, as you can imagine. So we have people tracking multiple things daily. And so, for example, if you have a group of 2 million individuals that you're looking at who are tracking data for a month, that's going to be 60 million data points. So you have to have a server that can handle this, a data analyst, and somebody who can help you clean it, and programming. And so it is a ton of data that you get all at once from these tracking applications if you're utilizing them in this way. I thought I'd just look really quickly at our data that we got for one of our projects, so you could see kind of like who's using it and like what are the challenges for researchers and the data that they then get, because it's not necessarily generalizable to the entire civil society. So, so for age, you'll see here that you can do tracking for younger individuals, but there's more protections about their use, and also the use of the application. They may need parental permission to use it. So you'll see here that the majority of individuals, the youngest you're going to see in most studies is 18 or age of consent. And then obviously, because people are usually tracking this for menstrual cycles, then you'll have an upper age of kind of 45-ish. So you'll see that the majority of individuals are kind of in the reproductive age, which if you're studying that area, that's great for you. Race and ethnicity may not be so important in for European researchers. This is something that we need pretty extensively in the United States because of our ongoing health disparities and racism. And so it's important for us to know our population. But this is something that is not required application for people to put in this information. So you'll see this blue area here. This is missing data for us. So we don't have the data around how people are identifying, which is a generalizability problem for research. And then finally, depending on what you want to do, you can only send out surveys in English. And so then that'll affect kind of where you're getting information from, the UK, Europe, US, Canada, Australia, New Zealand, and then other like South America. Sometimes we have some English speakers there too as well. Obviously, there's English speakers outside of this, and you can do your surveys in other languages, but that also can be challenging for research too as well. But you'll see that you'll pull on certain global regions, and so that can be also a problem with your generalizability too as well. And then finally, what does it mean when you have a blank calendar? This can be an issue with understanding how people are interacting with the app. And that's why it's really important to partner with your app colleagues, because they understand how people are interfacing with the application. Is it something that it's required that they interface every day? Can you put algorithms on this to kind of understand if people are tracking or they're just not tracking at all, or they're not tracking something specific in that day? And we've worked with a researcher in France, Dr. Alvarine, who's used some algorithms to help us understand that. This can be incredibly important for certain outcomes. For instance, if you're looking for periods of time for missed periods or amenorrhea, people might not track that if they're normally tracking menses. So they may be waiting to track, and it's hard to know if they're not interfacing with the app or if they're just not tracking. So it's really important to know kind of what your users are doing and how they're interfacing and how you can understand that better. And I'll end here with just a picture of my university. Yeah, we have a gondola. And then also, if you want to contact me about my experience with research or how to get connected, that's great. And here's some URL codes to some of our open access publications, so anybody can access them. And if you want to see our methodology and how we utilize these applications for research, there's more information there. So thank you so much.
Thanks so much, Alison. The health applications are so helpful, aren't they? And I think patients really engage with them. And I think we're all starting to realise the importance of these. So that was an excellent presentation. Thank you. I'm delighted to introduce our final speaker, Philipp Quaas, who is a senior physician and fellow at the University Hospital Basel in Switzerland. He's currently specialising in the field of reproductive endocrinology and infertility, with a main focus on contraception and reproductive health. Thanks, Philipp.
Thank you, Claire, and thank you, James and Petrus and Alison, for those wonderful presentations. And welcome to mine, novel contraceptive methods and myth busting. Those are my conflicts of interest. First, I want to ask, what is a myth? And if we take a look in the dictionary, we find that a myth is a traditional story concerning the early history of a people, explaining a natural or social phenomenon, and typically involving supernatural beings or events. An example for that would be ancient Greek myths, like the myth of Polyphemus, the Cyclops. The second definition of a myth is a widely held but false belief or idea, such as evening primrose oil helps to cure eczema, which is a myth according to dermatologists. And when we're talking about myths regarding contraception, we're mostly dealing with number 2. Where do myths regarding contraception come from? They come from inadequate sex education. They come from misinformation spread through the internet and social media. They come from cultural beliefs and religious doctrines. They come from historical misconceptions, and they come from individual experiences. One example where myths can originate is the Breast Cancer Prevention Institute, which was established by Angela Lanfranchi, which is a US breast cancer surgeon and anti-abortion activist, and she's active in the so-called American Life League. And on her homepage, she states that the pill kills and that the problem is huge. Over 61 million women are on the pill, and she states that women on the pill are more likely to have an myocardial infarction, a cerebrovascular accident, a pulmonary embolism, get breast, cervical, or liver cancers, get HIV and HPV, or die a violent death or commit suicide. She asks, is this what we want for young women? The pill kills. And what I think is really incredible is that, Angela Lanfranchi is actually publishing scientific literature in pretty much renowned journals, such as Frontiers in Behavioral Neuroscience, as you can see here. Where do myths come from? Of course, the social networks. Why is the birth control pill so bad for you? Pills cause blood clots and strokes, and influencers can't get over how big the package leaflets are and the side effects that are listed in those leaflets. There are also cultural beliefs that lead to myths. Take this study in Egypt, for example, where almost 90% of women were shown to hold at least one misconception, the most common being that birth control pills cause cancer or IUDs can travel to the heart. So what can we do, or what should we do? We should take facts that we do have in good literature and good scientific evidence and talk to our patients. For example, if you hear the myth COCs cause cancer, then you tell the patient that COCs do not cause cancer. They are actually associated with a decreased risk of endometrial, ovarian, and potentially colorectal cancer. We should analyze and assess the content on the social networks, see what people are talking about and which people are talking about what. And we could maybe use this content and this data to establish interventions to promote contraception in women of reproductive age. What we also should do is what my dear colleague Daniela Farana is doing. She's an influencer on TikTok, as you can see, and she has a lot of followers and a lot of likes, and she's educating patients, females, on topics of contraception and sexual and reproductive health, and she's producing high quality content, in my opinion. So the conclusion of this part is that we need to continuously inform and educate our patients according to the best of our knowledge and the best scientific data available. And we need to fight persistent myths regarding contraception and reproductive health. So now let's talk about novel contraceptive methods. And what I would like to do to put this a little interactive is that you are now very welcome to use your smartphone and scan this QR code, which you hopefully find on your screen. And I would like, because we have an audience around the world, I would like to hear, it would really interest me, what novel contraceptive methods do you know? And I hope that this is working. If not, I'm gonna just skip that. But we do have participants. We have the male pill, Larks for men, etonogestrel, the vaginal ring, apps, as Alison just presented very nicely. Very nice. We have new combined oral contraceptives. And as you can see, and I really appreciate your participation here, male contraception is a focus, and there are some things on the horizon that we want to talk about later on. Thank you so much for all this interesting input. Adam, wonderful. So what kind of contraceptive methods do we currently have available? As you all know, we have three big groups. We have the combined hormonal contraceptives, the CHCs. We have the progestin-only contraceptives, the POCs, and we do have the non-hormonal contraceptives, the NHCs. Of course, we do have emergency contraception and sterilization in addition. This is the set that we have and that we can offer to our patients in contraceptive counseling. And I'm very happy that we do have this set of options where you can really individualize the contraceptive methods to your patient. And in those different groups, there have been certain developments in the recent past. So in the group of combined hormonal contraceptives, we have an exciting new option, a COC, as you already put in the Slido, containing the natural estrogen estetrol, E4. And I think this substance is really incredible. It's kind of amazes me that this estrogen is only produced by the human species and is produced only during pregnancy by the fetal liver. And estetrol is a NEST, a natural estrogen with selective action in tissues. So it's a substance of its own. It has selective nuclear estrogen receptor alpha binding in endometrium, vagina, and bone, and it acts antagonistic on membrane estrogen receptor alpha, estrogen receptors in breast and liver. And those characteristics could be really useful and have shown very promising data in preclinical studies. So there is data that actually shows that estetrol can limit breast cell proliferation, benign and even malignant. And due to its profile, it has minimal impact on the liver and reduced risk for venous thromboembolism. It has also been shown that it's a limited cytochrome P450 metabolism. So this might lead to fewer drug interactions. I think the substance estetrol itself could be something which could become very relevant for future female hormone therapies. And then we have a new combined oral contraceptive, which is containing ethinyl estradiol dianogests, which is nothing new to you, of course. But this pill, Kelsey, is the first delayed release contraceptive pill. So we hope to see steadier plasma levels and fewer hormonal fluctuations. And we're looking forward to work with this new option. And one remark about dianogests as the progestin, which is contained in that pill, it has a partial anti-androgenic effect. That makes it a valuable new option because, as you all know, certain anti-androgenic progestins have not been put into the best light because of data which associates them with meningiomas, like cyproterone acetate, which is a progestin which I really like. We do have new patches, or a new patch and a new ring. We have the twirler, which is containing ethinyl estradiol and levonorgestrel. We hope to see lower ethinyl estradiol steady state levels in the user than with earlier patches. And one new option, which I really think is exciting, is a new vaginal ring, more or less new. The Anovera, which is containing ethinyl estradiol and segesterone acetate, nesterone. And what is incredible about this ring is that it can be used up to 13 cycles for 1 year, and you don't need to put it in the fridge. We have to be careful with those contraceptives still in patients with a BMI of 29 or more, because we don't know about its efficacy and safety. We have Also, new progestin-only contraceptives. We do have the Slinda or Slint with drospirenone, which is a really valuable new option in contraceptive counseling. This progestin, which is derived from spironolactone, has anti-mineralocorticoid and anti-androgenic effects. So it's a really good option to the POP that we used to have before, the only option, at least here in Switzerland and Europe, the desogestrel, especially for patients with risk factors that have a tendency towards the polycystic ovary syndrome. And then there is a new POP on the market, at least in the US, which contains norgestrel, which is related to levonorgestrel. And what's special about this pill is that it's OTC, is over-the-counter use, so you don't need a prescription. And then we have a novel LARC, a long-acting reversible contraceptive available now, which is called Miudella or Veracept, and it looks kind of special. I think interesting. The characteristics are that it has a nitinol frame, which is elastic and adaptable. It has less than half of copper of the standard IUDs that you might know, like Paragard or Mona Lisa. It has a smaller size, and what I really think is valuable is that it comes in a preloaded device, such as the levonorgestrel IUD comes. It has a tapered and rounded inserter tip and pre-cut strings. It's approved this year, or it has been approved this year for 3-year pregnancy prevention, longer pending trials, and in phase 3 studies, we have seen lower discontinuation rates because of bleeding and pain compared to the regular copper IUDs that we had before. I think I don't need to talk much about natural cycles. I think Alison, in her wonderful presentation, talked about that. A digital contraceptive, which uses basal body temperature and LH tests approved in the following countries there. It just shows you when you're fertile and infertile, red versus green days, and for a natural method or a cycle-based birth control, it has a pretty good effectiveness, a pretty good Pearl index, I think. So what's on the horizon? We have a lot of things on the horizon. I think what is very interesting to take a look at are biodegradable implants, such as this implant here, where levonorgestrel is loaded onto PLGA microspheres. This is a copolymer of lactide and glycolide. And this copolymer is biodegradable and biocompatible. So this LNG, PLGA components, they will be compressed to a tablet and then coated again with a biodegradable polyester. And preclinical studies have shown that if you implant that subcutaneously into mice, then the contraceptive efficacy will hold up to 90 days, and this implant will dissolve, so no removal needed. Another biodegradable agent are microneedle patches. Microneedle patches, they are just being administered to the skin, and then you detach the backing membrane, and those little microneedles will release the contraceptive drug. There are studies with levonorgestrel, and this is how those microneedle patches look. And in the microscope, they look like this. And if you apply this microneedle patch, you will see light irritation on the skin, but this will dissolve after 1 hour, and you will see nothing after 24 hours. So this could be kind of interesting. And studies have shown that with those microneedle patches, you would have steady release of levonorgestrel for about a month. Another thing which is on the horizon, at least studies state that, could be pharmaceutical contraceptive jewelry, where you have patches on a contraceptive watch, double-sided adhesive patches, or on a necklace. You can be very creative there. This could be the future of contraception, but I think we're not there yet. What about the male? So as you wrote in the Slido or suggested, we do have data on a contraceptive gel, which is containing progesterone acetate nesterone that is also contained in the vaginal ring that I introduced, or that has been introduced recently, and testosterone. We've always had problems with suppressing or with treating males for contraception with a hormonal-based methods because they had severe side effects. This regime and this gel, it actually showed less adverse effects in the ongoing studies, and it has been shown that 86% of the participants had reached a sperm count of less than 1 million per milliliter by week 15. That doesn't sound too exciting, but it's actually much faster than similar experimental hormone-based methods for male birth control have shown in the past. And this is a reversible mode of contraception, which is, according to the studies, the preliminary studies, also highly acceptable. And yeah, there are other agents which are currently under investigation, which inhibit either sperm production or sperm function. If you take, for example, the SAC inhibitors, they're pretty much on the way, maybe, of being an agent for the male birth control pill in a couple of years. So what they have been shown to be effective in studies is that you would take them, and then half an hour later your sperm would basically be immotile, and then you could have intercourse unprotected, and 24 hours later those sperm would move again. So that could be potentially a pill for the male for birth control. But this is all preclinical and far from studies on humans, actually. And then, as some of you suggested in the Slido, we do have something like an IUD for men, an injectable hydrogel for vas occlusion. It's a novel 2-component polyethylene glycol hydrogel engineered to be injectable in the vas deferens as an aqueous solution. It's biodegradable, and it would last for up to 2 years. This could actually be something which could be interesting. If you don't want to have a sterilization with its invasiveness, you could think about getting this nice hydrogel. And yeah, as a last male contraceptive option, which is actually kind of available in Switzerland, I want to introduce to you the sperm switch, the vas deferens valve. Basically, it's implanted at the vas deferens and on both, of course, obviously. And basically, this little thing has a switch where male subjects can just switch on and off if they want to be fertile or infertile. And this is the inventor of the sperm switch, and he is actually wearing those switches and is very happy with them. His name is Clemens Bimek. And with that, I thank you very much for your attention.
Thanks so much, Philip. There's lots of exciting possibilities on the horizon, isn't there? So we've got a good 15 minutes now available for a Q&A session. And we've had some questions coming in, so I can start with them. There is a question here for James and Petrus. What do you see as the most promising MPT candidates currently in development, and how do they compare in terms of contraceptive efficacy and STI prevention? If you're happy to answer that.
Yes, thank you very much for the question. And I think it's very hard to say what is most promising, because I think in contraception, we really look at choice. And so what is most important is to have a diversity of methods, including the MPTs. Of course, in terms of development, there are some which are have gone down the pipeline much further, like I talked about the dual pill, that are closer to market than others. But in the end, the impact of MPTs will depend on how much the preferences for the method of contraception align with what is in the MPTs. For example, the dual pill will probably be something that will be easier to use for people who already prefer using oral contraceptives, maybe not be as good for people who choose to use implants or injectables and so on. So I think the efficacy, of course, will depend on what is in the preparations. But what we look forward is to having a multiplicity of MPTs, really to provide the users with a choice. Thank you.
Thank you. And there is another question for yourself or Petrus, so we'll just move on to that. From a WHO perspective, what are the biggest barriers to integrating MPTs into existing family planning and HIV prevention programs in low and middle income countries?
Okay, I will take that one. It's always difficult to say what is the biggest barriers, because the barriers are very context specific. But if you look at general barriers, it can include issues such as relative cost of a method, where contraceptive tends to have a much lower cost than MPTs. And then also, of course, the complexities of dealing with dual products. And I think that is across the board, which will be a difficulty in training and protocols and as such. But as I say, I think it is also very context specific. Thank you.
Thank you. I wonder, I might just move on to some questions for Alison. There's a question here. How did you handle the politics around the question of COVID vaccines' impact on periods? Just knowing that there is obviously some vaccine hesitancy within the US, while also acknowledging people's period experiences and concerns. How do you balance all of that? It's quite a question.
Yeah, I mean, you guys will have to tell me if we did okay balancing it. I think out of all of the research that I've done in my career, we spent the most time with language on our publications to both recognize the fact that this is really important to people and their experiences may be represented in what we researched, or they may not be. And then also putting it in context around, the vaccine and connected with the vaccine. And I'll have to tell you, actually, so this was a mandated, which we would not see this right now, but this was a mandated research by Congress to the NIH to increase research around this, because they were getting so much public pressure about how it might impact menstrual cycles and women's fertility. And so we were lucky to be one of 5 research teams that were funded during this time period of when vaccines were being rolled out. And at the time, I didn't actually think we were going to get funding. And so our natural cycles colleagues were really nice about and generous in saying, like, we can run this first study even if you don't get funding. Let's go ahead and roll forward and see if we can get some answers for people. And that's why we were the first out the gates, because we had already started working on the publication before we had gotten the grant funding. It was a big challenge. And I think as a researcher, you know, it's the most I've ever heard from the public. Every day I was getting, you know, 10 to 20 emails about how people could participate, how they were interested in the results. And then afterwards I would get the same number, and some people were upset with the results and other people were very pleased to see somebody researching the results. So I figured if I was getting messages from both sides, that probably we hit the right balance on what our messages were. And then, of course, in the aftermath of all of this, we've received FOA requests from anti-vaccine groups asking if we're hiding anything or what my relationship with vaccine companies is, which is nothing. We had no relationship with vaccine companies. And so it's been an interesting process as a researcher to be in this space. I thought, you know, the work that I do in abortion care and sexual reproductive health was going to be the most kind of under attack, but actually the vaccines actually had a lot of pressure too as well. So it's been an interesting ride as a researcher in this space.
Well, yeah, I can imagine. And I know that there was also chat around whether the COVID infection itself affected menstrual cycles, not just the vaccine as well. So
yeah, well, you know, what was interesting is as we came out with the vaccine papers, then everybody flipped to, well, is it the infection? And so then, you know, we put out some science around that too as well, which the apps were great in producing that big data. And I think one of the other questions that I saw, which I can address just, you know, in relationship to this question is, you know, the safety signals. So, you know, randomized controlled trials can see like, you know, big, you know, adverse events or things that we think will happen a lot, but they don't see kind of like maybe smaller safety signals or things that the researchers in the randomized control trials aren't looking at. And one of the things that is not looked at all are menstrual cycles in vaccine trials. And so this wasn't something that we ever knew about. And many individuals that are doing vaccine trials might be on contraception because they don't want anybody to be pregnant during the trials. And so this is information that we just didn't have before. And so when there was the attention put on the vaccines and how the population was experiencing the vaccines, I think it was the first awareness actually in the United States that we had a vaccine tracking system with the federal government. And then you all have, in the UK, have the yellow card system where you can write in if you're experiencing something. So then the signals were seen, and then it had to be researched, like, is this just like a true unrelated incident? Or is this something that's actually related to the vaccine that they're getting? And so we were able to take this big population data and be able to see kind of what is actually happening rather than retrospectively saying, hey, did you have a change? Which it's very hard. And then if it's a really small change, having this big data allows us to see kind of the smaller change. But then as a researcher, it's really, you know, it's on us to kind of help people understand what population data means versus individual data. And so that can be very hard for people when they don't see their experience reflected in the population data.
thank you. Maybe just one more question, Alison, if that's okay. Based on your research, what types of patients are most likely to benefit from natural cycles? And then, if any, what scenarios would you advise caution?
Yeah, I mean, I think, you know, all of the apps are different for different reasons. And so some of them are better probably for some things. The interfaces are different for people. And so, you know, some people may want to track a lot of stuff. Some people may not want to track at all. Some people may want to do something that's low cost or free. You know, we know that people can use their smartphones to track. I think what is helpful is we all know as clinicians that support people in the individual contraceptive choices that they make, that they oftentimes, if they're choosing fertility awareness methods, the more that they're using and combining, probably the more effective it is for them. And so there are certain apps that really make that easy. So using natural cycles as an example, they now partner with, you know, your smartwatch or the Oura Ring, and they utilize basal body temperature. And as we all know in talking to patients about basal body temperature, it's so hard to kind of remember to do that at the same time every day and to use your special thermometer and do all of that. And so this links all of that together. And so that can make it very easy for people who want to combine that with their application and not even think about it because it's already, you know, talking to each other to be able to track your basal body temperature. And so there's some apps that are able to do that, and Natural Cycles is one of those. It's not that the other apps you can't input your basal body temperature, because you can, but you know, when it's easier, it oftentimes works better for people. So that's one of the positives around that algorithm that they use. And each app has its own kind of proprietary algorithm. And so that's where they vary a little bit too as well.
Thank you. I think, well, we've got a few minutes left, so I think we'll ask Philipp some questions. Philipp, one question's come in. What patients could benefit the most from the drospirenone POP?
Yeah, thank you for that question. So in Switzerland and Europe, we used to have exactly one progestin-only pill with desogestrel, which is a very good pill in my opinion, of course, but we were lacking something with anti-androgenic potential, especially for patients with risk factors. And as you all know, some patients with PCOS tend to have a slightly elevated BMI, and in those patients, when you couldn't use a combined oral contraceptive because of too much risk, in those patients, the new pill with drospirenone is, you know, a very, very good option and a very useful option. I like the also the anti-mineralocorticoid component, which has shown to be, I mean, we have to be careful with that, but shown to have beneficial effects on blood pressure and also metabolism. It has shown to be a good progestin in patients with premenstrual syndrome. There are a lot of applications, so I actually feel kind of bad for desogestrel because I don't see a point that much in prescribing it anymore, because drospirenone is just better. It has better cycle stability, better data, and so it really broadens the possibilities in patients with risk factors, especially.
Thank you. And there's a couple of similar questions. So somebody says that they agree about debunking myths and how critical that is. However, how can health providers strike a balance between debunking these myths and providing factual contraceptive information? And I also had a bit of a question about that, about how do we manage to access where patients are accessing all the misinformation, because I know within the NHS in the UK, we are not allowed to use these platforms to be able to debunk the myths, and therefore the misinformation just grows. And I just wondered, did you have any ideas or suggestions as to how as clinicians we can do that?
That's a good question. I think we just need to steadily and continuously talk to our patients, no matter you know, how big the opponent is. Social networks, and as we all know, people are not only getting their information regarding contraception on social networks, but almost everything is coming from social networks nowadays, and so I think we'll have to implement good programs, maybe web pages, maybe workshops, good promotion, good marketing, show the users or the patients good sources and bad sources, and make them try to reflect what they are being offered, that not everything they read and not everything which is presented really nicely and in a really good fashioned mode is the truth. But I think so. Claire, what you're saying is that you're not really allowed to use social networks too much. Is that right?
Yeah, certainly within the NHS, it's a real challenge just now.
Yeah. So, yeah, I think one example that I showed is Daniela Farana, and she's doing a great job in educating continuously and presenting good information and sources like that. We do need, and of course, content creators that users want to follow. Also the young patients, and yeah, we'll have to find out how to do that. I think we're kind of overwhelmed with the social networks. They just came like that, and just as artificial intelligence, I think with both instruments, we first have to learn how to interact and how to use them correctly. I think some things, but this is getting to metaphysically right now. They gotten out of hand, so we'll have to see how we can get this under control again, and then find a way to educate people.
Thank you. I'm aware of time. We have come to the end of the webinar, and there are quite a few questions that we haven't got round to being able to answer, but we're taking a note of them, and hopefully we'll be able to answer them at a later time, just not just now. I would just like to thank all of our wonderful speakers. I think it's been a really good webinar. It's been a joy for me to be involved. We've talked about some really interesting and current topics, and lots for us to think about. Thank you to you all who have attended today, and also to our sponsor, Bayer. And I hope you all have a lovely day or evening and weekend as well. Thank you.
Yeah, and at this point, thank you, Claire, for organizing this. You've done a great job.
It's been a pleasure. Thanks.
Thank you. Bye-bye.
Thank you. Bye.
Bye-bye.